In this second section, now we will discuss about the clinical manifestations or clinical features of tularemia, and also different types of tularemia, which include the oculoglandular tularemia, pulmonary and typhoidal tularemia. And also besides that, we will talk about some other manifestations of the tularemia. So the clinical manifestations are the sudden onset of fever and chills, headache, generalized myalgia and arthralgias, ulcer at the site of penetration, local inflammation, nodes enlarged, necrotic and suppurative. Widespread dissemination. So the clinical manifestation, as with most of the infections, there is fever, chills, headache, and there is myalgias, arthralgias. They are common with different infections. There is ulcer at the site of inoculation. We already mentioned in the last section that there is ulcerative lesion at the site of the inoculation is present. The nodules or the nodes are involved, causes lymphadenopathy and causes lymphadenitis, and lymph nodes of the areas which drain the organ involved usually becomes enlarged, like cervical lymph nodes, and then we have mesenteric lymph nodes get infected. So depending on the site which is affected, there is widespread dissemination of the infection. In adults, most common localized form is inguinal and femoral lymphadenopathy is common. In children, usually there is cervical lymphadenopathy. So children, the lymph nodes of the neck are enlarged and you can easily palpate them. And in the adults, the inguinal or the groin lesion or the femoral lymph nodes are the common lymph nodes which are affected. 20% patients develop generalized maculopapular rash. So in 20% of the cases, we have generalized all over the body maculopapular rash develops. Erythema nodosum occurs infrequently. So there is generalized maculopapular rash and there is erythema nodosum, which is infrequent. Clinical manifestations divided into syndromes. Now, the clinical presentation of tularemia in adults and children, how much percentage is affected and how much percentage of signs and symptoms develop in children and adults. Lymphadenopathy, which is enlargement of the lymph nodes, in 96% children and 65% adults. So it's more in the children as compared to the adults. Fever, which is more than 38 degrees Celsius or more than 101 degree Fahrenheit, 87 in children, 21 in adults. Ulcer, eschar and papule, 45 in children, 51 in the adults. So this is more in, excuse me. This is more in adults as compared to the children. Myalgias and arthralgias, 39 in children, only 2% in adults. So it's very common in children as compared to the adults. Headache, 9% in children, 5% in adults. Cough, 9% in children, 5% in adults. Pharyngitis, 43% in children, and diarrhea again 43 in children. So if we see the tularemia and the signs or symptoms of the tularemia are more severe, we can say, or the clinical presentation is more marked in children as compared to the adult. The only feature that is more in the adults is the formation of ulcer, eschar, and the papule. Ulceroglandular tularemia. Here you can see very, very big and large swollen lymph nodes are present. Ulceroglandular tularemia accounts for 75 to 85% of the cases. Inguinal femoral lymphadenopathy in adults. In children, cervical or posterior auricular lymphadenopathy is more common, related to tick bites on the head and neck. So in adults, we already mentioned inguinal and femoral lymphadenopathy is common. In children, it's usually the cervical or post-auricular lymphadenopathy. Epitrochlear lymphadenopathy or lymphadenitis in those with bite-related injuries. Ulceroglandular or glandular tularemia there is ulcer erythematous, indurated, non-healing. Papule begin as erythematous lesion. Ulcer gradually develop black base. Regional lymph nodes which are tender and enlarged. In 5 to 10% patients, skin lesion may be inapparent. Tick or deer fly bite on trunk may cause ulcer. So ulceroglandular or glandular tularemia, some features are there is ulcer which is erythematous, redness, indurated, non-healing. Papule begins as erythematous lesion. Ulcer develop black base slowly, regional lymph nodes which are very tender and enlarged, skin lesions may be inapparent, and tick or deer fly bite on trunk may cause ulcer. Clinical syndromes of tularemia. Now again the comparison in children and adults. First we talked about the symptoms and signs and the difference in the percentage of occurring among the children and adults. Now the syndromes which are ulceroglandular, 45% children, 51% adults. Glandular 25, 12. Pulmonary 14, 18, oropharyngeal 4, oculoglandular 2, typhoidal 2, 12, unclassified 6 and 11. So that's the comparison between the percentage of occurrence between the syndromes among the children and adults. Oculoglandular tularemia. In 1% patients, portal of entry for Francis tularensis in this case is oculoglandular related to the eyes. So the portal of entry is the conjunctiva. Inflamed conjunctiva which is painful. Yellowish nodule and pinpoint ulcers. Purulent conjunctivitis with regional lymphadenitis. You can see purulent conjunctivitis with the yellowish pussy discharge. Painful preauricular lymphadenopathy is unique. Here you can see preauricular lymphadenopathy. And there is corneal perforation may occur. Here you can see the corneal perforation. So all these are oculoglandular tularemias, clinical manifestations, how the patient will present. There is redness, pain, swelling, yellowish nodule, pinpoint ulcers, lymphadenopathy, purulent conjunctivitis, all these can occur. Oropharyngeal and gastrointestinal tularemia. Ingestion of now is gastrointestinal and oropharyngeal. It is related with the ingestion of the contaminated food mostly. So ingestion of contaminated undercooked meat. Oral inoculation of Francis tularensis from hands, dirty hands. Skinning and cleaning of animal carcasses. Consumption of contaminated food or water and infected tonsils enlarge, develop pseudomembrane. So tonsils become enlarged also because it is oropharyngeal tularemia where we have tonsils present. They become enlarged, swollen, tender, painful, and there is covering of the membrane on top of the tonsils, which is a pseudomembrane. Here you can see the picture of the gastrointestinal tract with the tularemia. Oral inoculation may result in diarrhea, abdominal pain, nausea, vomiting, gastrointestinal bleeding, acute exudative or membranous pharyngitis associated with cervical lymphadenopathy and ulcerative intestinal lesions associated with mesenteric lymphadenopathy. So we already talked about this, that the lymphadenopathy is prominent in the region which drains the area that is involved. In case of GI tract, mesenteric lymphadenopathy. In case of oropharynx is cervical lymphadenopathy. With the oropharyngeal tularemia, there is enlargement of the tonsils also, which becomes swollen and tender. There is nausea, vomiting, gastrointestinal bleeding, and pharyngitis is inflammation of the pharynx developed, in which there is sometimes also the formation of membrane or exudate on top of the pharynx. In fatal cases, extensive intestinal ulceration is present at autopsy. Pulmonary tularemia, inhalation of infectious aerosol. So this tularemia is due to inhalation of the aerosol, which is infectious aerosol. Non-productive cough is present. Dyspnea or pleuritic chest pain. There is shortness of the breath. There is pleuritic chest pain present because of the inhalation of the infected aerosol, and it causes pulmonary tularemia and like a pneumonia. Variable parenchymal infiltrates unresponsive to treatment with beta-lactam antibiotics detected by chest röntgenography. Empyema may develop. Blood cultures positive for Francis tularensis. Röntgenogram of chest reveal bilateral patchy infiltrates. Here you can see bilateral patchy infiltrates. Lobar parenchymal infiltrates, cavitary lesions. Pleural effusions have predominance of mononuclear leukocytes or polymorphoneutrophils, and sometimes RBCs. So there is empyema may develop, formation of the pus. Blood cultures are positive. Pelchi infiltrates are present on the X-ray. Lobar parenchymal infiltrates, cavitary lesions. Then we have pleural effusion, have predominance of mononuclear cells and polymorphoneutrophils and sometimes red blood cells. Typhoidal tularemia. Source of infection is associated with pharyngeal or gastrointestinal inoculation or bacteremic disease. Fever usually develops without skin lesion or lymphadenopathy. Cervical and mesenteric lymphadenopathy is present in some cases. Blood culture may be positive. Patients may develop classic sepsis or septic shock associated with huge inoculum, high continuous fever, signs of sepsis, headache, and may develop prostration and shock. Some other manifestations include meningitis and pericarditis, hepatitis and peritonitis, endocarditis and osteomyelitis, sepsis and septic shock with rhabdomyolysis and acute renal failure. So all these are some other manifestations of tularemia which are quite serious and severe. Involvement of meninges, pericardium, liver, peritoneum, then we have endocardium of the heart, bones, acute renal failure can also develop. So all these are some other manifestations. In case of tularemia meningitis, there is mean white blood cell count of 1788 per microliter, predominantly mononuclear cells, depressed glucose level, decreased glucose, increased protein level, and there is negative gram stain found on examination of cerebrospinal fluid. So that concludes our section 2. Thank you for watching sqadia.com.